Hi, everyone. Welcome back to Oncology Data Advisor. My name is Rahul Banerjee. I'm Assistant Professor of Medicine at the Fred Hutchinson Cancer Center in Seattle, Washington. And today, it's my pleasure to speak with Dr. Shonali Midha to get some updates from the 2023 International Myeloma Society meeting that took place a couple of weeks ago at the end of September in Athens, Greece. Dr. Midha Shonali is a myeloma expert at the Dana-Farber Cancer Institute in Boston, Massachusetts. She's also an instructor in medicine at Harvard Medical School and was also one of the oral presenters at this conference, the IMS meeting at the end of September in Athens. Dr. Midha Shonali, pleasure to have you joining us today.
Thank you so much, Dr. Banerjee. It's my pleasure to be here today.
Wonderful. So, as I alluded to, you were one of the oral presenters, and I think what you presented was kind of basically, real world data with teclistamab is something I would love to spend some time on. So maybe we can start there. So teclistamab was approved in the U.S. just about a year ago in October 2022. Can you tell us a bit more about this drug and the Majestic-1 trial that led to its approval?
Absolutely. So teclistamab is a BCMA CD3 bispecific T-cell engager that is approved in the relapsed refractory setting after 4 lines of prior therapy in multiple myeloma. It was approved, as you mentioned, back in October 2022, based on the Majestic-1 study, which was a phase 1, phase 2 study of teclistamab in patients that have received 3 or more prior lines of therapy with relapse refractory disease. In the Majestic study, patients did not have any CNS disease and were not considered eligible if they had had significant kidney dysfunction with a creatinine clearance below 40. It did allow patients with a performance status of 1 or better, so relatively healthy patients overall. And I'll explain why I'm harping on that fact in a moment.
I know why,
Um,
and the audience might guess why, but keep going. Yes, indeed.
yeah. So that in their phase 2 portion, and overall, they had included 165 patients with an overall response rate of 63%, which is very exciting for, I think, a single agent therapy in this setting in patients that are so heavily pretreated that had received a median of 5 prior lines of therapy.
Great. So as you alluded to, you're kind of setting the stage here. So you presented your institution's, real world experience. Can you describe what the results were, how the patients were, any surprises or lessons learned compared to the published results from Majestic-1?
Absolutely. So we presented our data, a single institution retrospective analysis of patients treated with teclistamab in the commercial setting. So those that had, again, received 4 or more prior lines of therapy. In regards to the demographics, our age-wise, our populations were very similar. Our median age was 69 as compared to 64 with Majestic. Obviously, we did have more patients with a poorer performance status at the time that they started therapy. So about almost a third, about 30% of our patients had an ECOG status of 2 or greater. We had more patients that had high risk disease, either defined by a stage 2 or 3 revised ISS stage, or by high risk cytogenetics. We had over a quarter patients with a 17p deletion. We had up to 40% of patients that had a 1q gain or amplification, and overall 59 or 49% with high risk cytogenetics. We had 42% of patients that had extramedullary disease, so another high risk feature in myeloma, and 7 patients, or about 12.5%, that had CNS disease. Of the patients we treated, 20 had prior BCMA therapy, 13 of which had received prior belantamab mafodotin, which is an antibody drug conjugate, and 13 that had received prior BCMA-directed CAR T therapy. So as you can tell here, there were some patients that had received more than one BCMA-directed therapy in the past. So it definitely does go into some of the results that we see as well. Of our patient population, which was 56 patients treated total between the time of FDA approval and our data cutoff at August 15th, we had treated 56 patients. 80% of those patients, or 45 patients, would not have been eligible for Majestic-1,
Mhm.
either based on renal dysfunction, presence of CNS disease, or cytopenias at the time of treatment. So in regards to some of the toxicities that we're seeing and the safety signals, we actually saw very comparable rates. We had 52% of patients that had experienced any cytokine release syndrome, which was not too far off. That was seen in 72% in the Majestic-1 study. We had very few grade 3 or greater events, only accounting for a little under 2% of all cases. And actually, our median onset of CRS was later than what was seen in Majestic-1. They had cited a median onset of 2 days. We had a median onset of 5 days, and a duration of CRS that was about 2 days, again, similar to Majestic-1. We had very few neurotoxicity events. We actually had only one documented event, so about 2%, no grade 3 or greater neurotoxicity events, and 14 cases of tocilizumab use, so about a quarter in regards to percentage. So also something interesting, especially given the number of patients with CNS disease.
Before you get to efficacy, I was going to ask, was that one case is someone who had CNS disease or it didn't?
So that one case was a patient who had received radiation for suspected CNS disease.
Fair.
And our thinking at the time is whether there could have been an abscopal effect. It was actually a very transient neurotox event. It was wrist drop that only lasted for a couple hours. They actually did not receive any DEX by the time it had improved. So their symptoms of it actually had improved prior. They had happened to receive radiation. They had ongoing radiation during the time of the step up. And so we were wondering if there could have been an abscopal effect that we were seeing there.
Which is fascinating. And just for the audience, the abscopal effect would be that the radiation sensitizes other cells in the area or other basically like immune cells to kind of get in gear.
Exactly.
Wonderful. Okay, sorry, I interrupted you before the most exciting part. So now efficacy in this much sicker, much more real world, literally real world population.
Exactly. So what was exciting was despite treating a very sick population and a heavily pretreated population, we saw a response rate of just under 54%. Obviously, this was better in patients that had not received prior BCMA-directed therapy. It was around 58.3%. Those that had received prior BCMA therapy, the response rate was at 45%. I think what was also really encouraging here was that we saw a response rate of 37.5% in patients with extramedullary disease. But as expected, when you look at the breakdown of those patients that had received prior BCMA versus those that had not, the patients that had received prior BCMA-directed CAR had a lower response rate, about 30.8%, as opposed to those that had received antibody drug conjugate. So definitely somewhat sobering to see, a slightly decreased rate in patients that have received prior BCMA-directed therapy, but still a very good option even in patients that are heavily pretreated and with more comorbidities or disease status, greater disease burden at the time of treatment.
Agreed. If I may, I'll delve into, I think what I found striking about it is that, yeah, for us, our patients with CNS involvement often do very poorly. We talk about pomalidomide, we talk about selinexor, drugs that maybe cross the blood-brain barrier, or chemo, and that's it. I know it's small n, but still, 7 more, 8 more, however many patients it was, 8 more than however I've personally treated with teclistamab in this setting. Did some of those patients do okay, or even had CNS clearance or resolution of, EMD in the calvarium?
Yeah, so we actually did not include that as part of this cohort here, but we have looked at our patients we've treated that have had documented CNS involvement, either radiographically or by CSF or, leptomeningeal disease radiographically. And out of the 7 that were treated, 5 had a documented response, so a PR or better, which was very encouraging. 2 of those patients had received radiation for their CNS disease as well. So, I think this is a therapy that does provide those patients benefit.
And this is very helpful, and I did not know that. So thank you for sharing that on the fly. And I think, yeah, obviously small n, more studies are needed, but I think both
Exactly.
showing that for those patients, obviously many patients benefit from teclistamab, as you alluded to, but those patients in particular, everything scares us about them. We're so worried about neurotoxicity. It sounds like maybe, the rates are low of ICANS in those patients and others, and some of them do respond. Wonderful.
Absolutely. But I think one thing which we saw, as well as has been very well documented with BCMA-directed bispecifics, is the infection risk,
Sure.
right? So out of our 56 patients, we had a documented 32 infections in 26 patients, of which almost half, 48% of those, were grade 3 or grade 4 infections. We did not have any teclistamab-related infectious deaths. However, we did see a large proportion of those infections were respiratory, the majority being upper respiratory infections, comprised of 37% of the infections seen, and then pneumonia comprising another close to 20%. Of the respiratory infections, under half, about 46%, were COVID cases.
Mhm.
And then we did see, again, a decent amount of skin, soft tissue, gastrointestinal, and GU infections. So definitely something that we still have to keep an eye out for and learn a little bit better about how best to manage or mitigate.
That's very helpful to hear. Yeah, because I think a lot of us often, assume that maybe some of the reason that the infection deaths were so bad with the BCMA trials that they're running in the early days of COVID. Here, you said these are all patients treated commercially, so all in the last year. And so, you could argue that COVID, we've had vaccines now, the virus has mutated, but it still sounds like a serious threat. Maybe not life-threatening, not grade 5, thankfully, but
Right.
a lot of patients still are getting ill.
Absolutely. So I think it's something we still have to learn best how to manage and decrease the risk for, whether it's alternative dosing, looking at other ways of scheduling dosing, or prophylaxis.
That's exactly right. Exactly right. Hopefully, by this time next year, we'll have more exciting, or maybe more exciting COVID treatments that we can use, something like Evishield for prophylaxis. Great. So then, switching gears, and now we can talk about some of the other interesting abstracts that IMS and you and I had discussed briefly beforehand. So you focus now on teclistamab in the relapsed refractory setting, heavily pretreated patients. You did allude to a lot of these patients being higher risk and more higher risk patients in your cohort than in Majestic 1. So let's focus on high risk and pivot now to frontline setting. The GMMG concept study was also presented looking at ISA-KRD, that's isatuximab, carfilzomib, lenalidomide, and dex in high-risk myeloma. Any thoughts about that, either that trial or about anything from IMS that changes how you approach or how you treat high-risk myeloma diagnosis?
I mean, I think it was definitely a very interesting trial, right? Looking at specifically a high risk population, um, taking into account within that high risk population, I think it's one of the few studies that's taken into account a 1Q amplification. They did use the second iteration of the revised ISS staging that factors that in, which I think is not a group that we have very well studied, although comprises a large proportion of myeloma patients. From that perspective, it was very encouraging to see incredibly high rates of MRD negativity with isatuximab, carfilzomib, Rev, and Dex treatment up front. Seeing MRD negativity rates for both transplant ineligible and transplant eligible that are above 54, 50, and 67% is highly encouraging.
Agreed.
And I think, as we learn more about the role of MRD negativity, it may not be the be all end all, but knowing that you can achieve a deeper level of response up front, I think is something that gives us pause, and especially in a high risk population.
Agreed. Agreed. And that's helpful to hear. I mean, I know in the US, at least for our listeners, isatuximab is not yet FDA approved for frontline therapy, but agreed. I think it's showing that, maybe this type of approach works. And Dr. Midha alluded to the transplant ineligible patients were also included on this study as well. So it's not just like a one pathway, kind of like a way of life using quadruplets and then rolling with it. So great. The other study that comes to mind for me is Canova, which actually we'll be, for people listening to this, we're going to be doing another podcast with Dr. Yee, specifically Andrew Yee from a different institution in Boston, specifically about T1114, I'm sorry. But I'm sure that's probably the one that turned the most heads at IMS. Can you catch us up to speed on the Canova trial and maybe how it informs or doesn't inform your practice since returning from Greece?
Absolutely. So the Canova trial was a phase 3 study looking at venetoclax, dexamethasone, as opposed to pomalidomide and dexamethasone in patients that have relapsed refractory myeloma, have received greater than 2 lines of therapy. And so they looked at patients that did have a translocation 1114 that is suggestive of BCL2 expression, for which venetoclax is a BCL2 inhibitor, and one of the few targeted therapies available in the myeloma space. And so what they found, keeping in mind that patients in the venetoclax arm had a slightly higher median prior lines of therapy. I believe they had 3 as opposed to 2 prior lines in the POM Dex arm, and did treat a variety of patients. One thing I did want to point out here, and I think is something that we continue to work on in myeloma space, is they had a very low percentage of patients that were African in descent or Latin in descent. And that's, I think, an area where we have to work a little bit harder, especially because we know that translocation 1114 is more prevalent in those populations. So I think we do have to take this data with a large grain of salt there, right? That being said, while they did see a numerically larger progression-free survival in patients treated with venetoclax and dexamethasone as opposed to pomalidomide and dexamethasone, it was not statistically significant for the statistical analysis of this study. I think it was in regards to kind of how to take that. It's definitely hard to beat pomalidomide and dexamethasone. We've seen that in other studies. But I think it also shows us that maybe venetoclax is not a medication we can use as a doublet. I think we did see higher response rates in patients treated with venetoclax Dex as opposed to pomalidomide Dex. That was statistically significant, almost double of what it was with pomalidomide and Dex. So there is a role for treatment with a BCL2 inhibitor, but it may not be strong enough alone.
But very well stated, and that's true. And the Bellini study had bortezomib. Dr. Kaufman presented with carfilzomib. So if you do use right now, it's off label, obviously, but if you use venetoclax in any scenario for T1114 myeloma, how do you typically do it in your personal practice?
In my personal practice, it's often in times in combination with a proteasome inhibitor,
Sure.
Either Velcade or carfilzomib, depending on tolerability and the patient's comorbidities.
Absolutely. Well, thank you, Shonali. Thank you, Dr. Midha. This was interesting. It was a very whirlwind meeting in Greece for all of us. And I think hopefully, I always say that hopefully a year from now, everything we talked about will be out of date with more data, not the real world teclistamab, but everything else will kind of change, see more and more data about how these things unfold.
Exactly.
So with that, thank you again for your time. And this has been another episode of Oncology Data Advisor. Thank you to everyone for listening.
Thanks for having me.